Elliott Antman, President of the American Heart Association, here for AHA Science News in Barcelona at the European Society of Cardiology annual meeting. And one of the most exciting trials, Mariell, was the Paradigm HF trial. And I know you've been thinking about this a lot, and you wrote the editorial in the New England Journal. So let's try and put this in context. How many people have heart failure in the United States? And I know we talk about reduced and preserved ejection fraction. So let's just start with that.
So 42 million people in the world have heart failure. And in the United States, we estimate that about 6 million people have heart failure. Our risk of developing heart failure as we get older is about 1 in 20. So we have a high incidence of developing heart failure. Men are more likely to get heart failure with reduced ejection fraction, poor contractility, but women can also get this. So it is the #1 reason why people are put in the hospital over the age of 65, and it costs our economy, our health economy, millions and millions, up to the billions of dollars.
We have an increasing age of our population. We have all noted the fact that heart failure is going to be an even bigger problem for us over the ensuing decades. We have therapies for heart failure now. What are the benefits and, importantly, the limitations of some of our therapies that are available now?
Well, let's just dispense for a minute with heart failure with preserved ejection fraction, where still we don't have any proven therapy that will extend survival in that significant patient population, which is about half of all heart failure. Here's where the good news is that in heart failure with reduced ejection fraction, where this new drug is possibly going to be applied, we've had a very good regimen, but it's been unchanged really for almost a decade. And the principles and the pathophysiologic pathways that we've utilized to treat heart failure have remained unchanged for more than 25 years. So we needed a new drug, and this is a novel drug that is combining two chemical entities, an angiotensin receptor antagonist and a neprilysin inhibitor. So it's two pathways combined into one drug that seems to have caused these remarkable findings in Paradigm.
Let's try and put this in perspective another way. And I'm thinking about it from the experience I have in the acute coronary syndrome field, where we're always adding another drug on top of the ones that have been proven to be effective to date. But this seems to be a substitution of a new combination therapy for one of our standard therapies. Can you put that in perspective for us?
So ACE inhibitors, and in this trial specifically enalapril, has been the gold standard of therapy. We were instructed to use enalapril or an ACE inhibitor before even an ARB because of their efficacy post-myocardial infarction and in HFrEF, heart failure with reduced ejection fraction. And this trial went up against, it was not a placebo-controlled trial, it was against 10 milligrams BID of enalapril. So they went for the whole enchilada, and they won. So in this trial, the investigators at the end of the presentation advocated that LCZ696 should be substituted for enalapril. So changing the entire optimal medical therapy for heart failure in an important way.
Excellent. One last point that we want to discuss is surely the results of this trial with this novel agent will be reviewed by the regulatory authorities around the world. Let's just talk about the FDA for a moment. How long has it been since a new drug for heart failure has actually been approved by the FDA? And I know you've been struggling for a while. Give us some perspective on that.
So the last time the FDA approved a drug for HFrEF was in 2005, where they approved the drug Bidil, which was a combination drug of hydralazine and isosorbide dinitrate. However, it was only for self-identified African Americans who were symptomatic despite optimal medical therapy. So this will presumably be applicable to all Americans. And also is not adding on, as you said, it's substituting one of our drugs. And I know our patients are really going to appreciate that, because for once we won't be saying you're going to take all of these pills and this new pill. We're going to say we're going to substitute LCC 696. It'll probably have a new name for your ACE inhibitor.
Mariell, it's been wonderful talking to you about this. You're an international expert on heart failure. You're the immediate past president of the American Heart Association. And I know you've been thinking about this trial for quite a while. Appreciate the opportunity to talk to you about it. This is Elliott Antman for AHA Science News here in Barcelona.